where it starts with a statement like it's the worst of times, it is the best of times. So it is now probably the worst of times in India and Corona. And possibly this kind of what you call as a Zoom or a team meetings are primarily as an after product of this coronavirus. And the lower half of the slide, you can see two big events happening, and one very pleasant happening, that is SpaceX docking with the International Space Center. And on your right side, you can see a very painful process about George Floyd being beaten up, killed by a white policeman. And one statement I want you, young people, you are basically my students. So Meghan Markle, we only knew her as a wife of Prince Harry. But the statement she made yesterday, I think it is very important for everybody, including Indians. That is, the only wrong thing to say at any point of time is to say nothing. I think with that, I will start my business of pediatric X-rays in cardiology. And again, in between, we will pause and seek questions and try to answer that. This gentleman got a Nobel Prize in 1901 for X-rays, William Röntgen. And a little later, maybe around 10 years later, Einthoven also got a Nobel Prize for electrocardiography. So both these people are very, very important people to as cardiologists or any physician for that matter. Now the question is, when do we take X-rays in pediatric cardiac illness? Of course, in the diagnosis of a newly suspected congenital or acquired heart disease. Suppose you diagnose already a situation and we want to periodically assess the diagnosed cardiac problem, not in all, but in some of them. And of course, very importantly, for those people working in a pediatric cardiology center, a post-operative or a post-procedure cardiac evaluation is also needed. Now, another question which we ask, just like our stethoscope, why do we still take X-rays in spite of various new entrants like echocardiography? We have, of course, now a handheld echocardiography now, or an angiography, or a cardiac MRI. So in spite of that, we still continue to take X-rays. It is mainly because it is very commonly available, it's very cost effective, it is simple, and it is directive. It directs us to a particular situation. For example, if you have a heart sound in a newborn baby, it appears to be more common, more well heard on the left side or the middle. You take an X-ray and you see the heart on the right side. So it's very easy to do this. And it helps, of course, in the diagnosis, differential diagnosis, prognosis, follow-up, and of course, sometimes in treatment. And this chest X-ray is a window to the heart, the lung, and the vessels, because they are intrinsically, intimately interrelated. And also we will have a look at the mediastinum, the bones, the soft tissues, diaphragm, and of course abdomen, which is very important. I put specifically why, because we are dealing, suppose you are dealing with a malposition, abdomen becomes very, very important. So the approach to a cardiac evaluation of by an X-ray would be to see whether there is an anatomical abnormality or is there a physiological abnormality.
So usually electrocardiogram,
you look at the chambers, you look at the valves, the layers like myocardium and pericardium, the great vessels, vein and all. And physiology, of course, you look at blood flow to the lung, or is there an evidence of a heart failure, pulmonary hypertension, etc., etc. And of course, having looked at the lung and its companions, we should always look at the extracardiac features, if any. Look at the lung, of course, pneumonia, hypoplasia, rib notching, all these things can cover in the bony cage, and of course the mediastinum and soft tissue. So then only it becomes a complete evaluation of a chest X-ray in a suspected heart disease, either congenital or acquired. And the usual source image between the X-ray film and the source is around 6 feet, maybe a little less for pediatric practice. And in pediatric practice, the problem is the respiratory rate is very fast, so that the exposure time has to be less than 100 millisecond. And the child ideally should be in an upright position. But we know that the majority of the pediatric cases are infants who cannot be kept in an upright position. So what we intend to do will be a PA view, but what we will get is an AP view. And ideally, the inspiratory film is preferred and the diaphragm at the level of the 9th rib. But these things are very difficult, especially when you are dealing with an infant, especially below 6 months of age. Now, if you take an X-ray and heart disease, you of course can have a normal heart and a normal X-ray, and abnormal heart of course in an abnormal X-ray. But sometimes you have a normal heart, but there will be an abnormal X-ray like a spurious cardiomegaly. Sometimes the heart may look absolutely normal. There will be a 3/6 murmur, maybe a small ventricular septal defect, so the X-ray may be absolutely normal. So you must be mentally prepared for this. Now, what is the ideal situation is the inspiration, that is the diaphragm would be at the level of the 6th anterior rib and 9th or 8th posterior rib. We will see those X-rays later. And this, of course, is also very important for a young cardiologist, young pediatric cardiologist, because an X-ray has a radiation of 0.1 millisecond, and a CT just is 7, which means 70 times. Even with the modern CT machine, you have 70 times, and even with the modern machine, 120 times taking an X-ray, that is CT, coronary angiogram. This is very important because some people have a habit of doing a CT angio for a Kawasaki disease to assess the coronary artery, which could be easily done by a non-invasive, non-ionizing evaluation by an echocardiography. So you must be very, very careful when we plan for X-rays also. And we know that previous time when we were students, it used to be taken in a standard machine. We have the PA view, AP view, and a lateral view, and now can be also in the portable view. And the portable problem is that only AP view is available, and there is always an apparent cardiomegaly. And the current scenario, especially at least in the corporate hospitals, you have a direct format where there is no film, only image. Sometimes you have both image and film you can get, so that you can send the film with the patient. That would be, of course, in a way better. Anyway, now look at the anatomy of the heart. As you can see here, you have the heart somewhere in the middle, and you have the right atrium on the lower half of the right side. And you can see aorta coming up and could also form a border on the right side and superior vena cava. On the left side, it's very clear. You have the aorta bending, and then you have the pulmonary artery and LA appendage, and of course a left ventricle. This is the usual thing, which of course in a real X-ray you can see this, a right atrium on the right side, SVC on the right side. But a right atrial appendage and aorta not very commonly perceived in a routine X-ray, but you could expect that if they are abnormal. And on the left side, of course, definitely you have an aortic knuckle or a knob, pulmonary artery segment, LA appendage, not LA appendage segment, and left ventricle forms the apex in a normal situation. So we know that on the left side, the border forming structures are aortic knuckle, PA segment, LA appendage, left ventricle, and on the right side, basically superior vena cava and a right atrium, and possibly an ascending aorta. These are very simple things, but once in a while, the examiners are very interested in asking these questions, and they would call it as what I call basics. Yeah, please. So this is a normal X-ray. Actually, it's absolutely not normal. It has a bicuspid aortic valve, so that just to show you the what you call aortic knuckle, I've taken this X-ray. This is the aortic knuckle, and the rest, you know, You have the right atrium and the upper half is only SVC, and on the left side aortic duct followed by a pulmonary artery segment followed by a little concavity which is the site of LA appendage, and beyond that is the left ventricle. Then lungs, you divide the lung mentally into three areas: a medial portion, middle portion and a lateral portion. Vertically, you divide mentally the lung into two zones. It's not anatomical, it's just for your reading purpose, an upper zone and a lower zone. And another very important thing is that the relationship between the heart's position and the diaphragm. As you can see here, wherever the apex is, will be the lower dome of the diaphragm. So when we suspect a dextrocardia, and if you feel that it is truly a dextrocardia, so that the apex is pointing towards the right side and the diaphragm should be a little lower than the opposite side, contralateral side. So this could be very useful in deciding is it a true dextrocardia or a pushed or a pulled heart, which we call as a dextro position. Which view? Standard view is a frontal view. You can of course say PA view and an AP view. The rest of the views are nowadays not very important. And of course, whenever you start reading an X-ray in a Viva or anywhere, you should definitely try to see whether it is a PA view or an AP view. 2 points are very useful in assessing this. One is the prominence of the spines and the obliquity of the ribs. For example, this X-ray does not show the prominent spines, and as you can see very well, the ribs are oblique. So this is a PA view. Whereas this X-ray, you can see the spines very clearly, and the ribs are horizontal. They are not oblique. So you have this AP view, and generally below 6-1, even if you ask for a PA view, what you get is an AP view. You should know that. So if you compare these two X-rays, you can see the difference between a PA view and an AP view. And honestly, sometimes it could be a little difficult. So even the radiologists are saying that if you're not sure, you say chest X-ray frontal view. And if you're very sure, you say PA or AP view. Nobody will harm you. Now, we start with this X-ray, and we want to know where is the major cardiac shadow. It can be on the left, which is normal, which can be on the right, which means it could be a true dextrocardia, or a pushed or pulled heart, which I told you is dextro position. And somewhere in the middle would be a midline heart or a mesocardia. So you see these three X-rays. The first one, as you know very well, is on the left side. The second one is the middle pathway. And of course, the last one, of course, is a right pathway. Not in that sense, it's a right-sided pathway. Now, so if you have a dextrocardia, what it means is that the major cardiac shadow on the right with apex pointing to the right. We'll come to that again later. Whereas dextro position is a major cardiac shadow is to the right, but it is due to, as I told you, a push or a pull. And once you commit whether the heart is on the left, on the right, or in the middle, you immediately commit on the situs, looking at the lower half of the X-ray, where invariably you will find a liver and all. So liver on the right, stomach on the left is solitus, and liver on the left and stomach on the right is inversus. Most of you must be wondering why these simple things are being said, but I think there's a purpose, because always you should know the fundamental what we learn in the final year MBBS posting. And this, of course, very clearly, the heart is dominantly on the left, liver is on the right, stomach bubble, fortunately for us, is definitely there. So you have a true levocardia. Now this, of course, is a dextrocardia, no doubt about it. As you can see, the major shadow is to the right, the base to apex axis is to the right, and liver is on the left. And so naturally, this is a dextrocardia with situs inversus. We know that very well. Look at this. Again, the heart is towards the right, but liver is on the right. So it is a dextrocardia with situs solitus. You have seen one normal dextrocardia with situs inversus, and this is a side dextrocardia with situs solitus. And this is somewhere in the middle. It is very difficult to comment on the where the apex is moving, whether it is towards the left or right. It is very tricky thing, so don't comment on the apex. It is a midline heart. That's all you can see. Be very honest in reading. Whatever you see, you tell. Don't put too much imagination into your reading of an X-ray, because as you know very well, in this current era of echocardiography, anything can be possible. So we be very humble or honest in assessing a chest X-ray or an electrocardiography. Now, this was an X-ray. I still remember as a young person, as a cardiologist, we had this X-ray with respiratory distress, was referred to us as dextrocardia because the heart sound was, and child was little blue also because of respiratory distress. We thought there must be a dextrocardia with very complex congenital heart disease. An X-ray was taken, and later the echo also taken. It showed only a pushed, pulled heart. If you look at very carefully, you will find there is some crowding on the right side. So there was actually on CT, this showed a significantly hypoplastic lung on the right side. It was actually pulling the heart towards the right side, what we call as a dextro position. So this, I think, is very important for you in the examination on real life. When you get dextrocardia with situs inversus, what we call as a mirror image dextrocardia, the chance of a congenital heart disease very low, 5%. But you should remember that in control population, the prevalence of congenital heart disease is 1%. So whatever said and done, in a dextrocardia with situs inversus, you are like once in a while likely to find an abnormality. Whereas if you have a dextrocardia with situs solitus, that is where you get 90% will have some sort of congenital heart disease. And there's a very interesting situation which I will show you later, where you have the heart will be actually on the left side, but there will be situs inversus, where practically all of them will have congenital heart disease. Very rare, but these X-rays can be kept in your examination. So we have looked at the location of the heart, number one. Number two, we have looked at the situs also. Now the third thing is you assess the cardiac size in an X-ray. The assessment can of course be subjective or objective. Look at the CT ratio, and I need to tell you how to do a CT ratio. But basically, I believe that a good clinician can subjectively, on eyeballing, can assess almost exactly the CT ratio and can make a reasonably good diagnosis or whatever. But for information purpose, this is the definition of cardiomegaly in pediatric practice. In the newborn, anything above 57%. You try to make this 60%. That is easier for you to remember. Anything 60 or above in a newborn would be considered cardiomegaly. Infants above 55 would be considered, and the child, of course, more than 50% will be considered as mild more cardiomegaly. This X-ray, even by eyeballing, you don't need to do a CT ratio. You know that it is a normal sized heart. This definitely is enlarged. You can say mildly enlarged. This is moderately enlarged. And this is a marked enlargement, massive cardiomegaly, you can see. So this is how you look at this. And if you have enough time and the inclination, of course, you can calculate the CT ratio. And you should remember one point, they can ask you, at what level will you do this thoracic diameter? The level is at the right dome of the diaphragm in the usual situations, but there can be exceptions. Now, sometimes we may see a small heart. What is a small heart by definition? CT ratio less than 40%. Classically, Addison's disease. severe PEM, protein energy malnutrition in pediatric practice, anorexia nervosa, and a relative small heart in a COPD, as you know very well. So these are the very few situations where you get a real small heart. So you have the location, the situs, the size. Now you look at the cardiac contour. Basically, what we are trying to do by looking at the contour is to see whether there is a predominance of the right ventricle or is there a predominance of the left ventricle. As you know very well, apex is of course formed by the left ventricle. So RV contour, as you know very well, is a rotated apex, and the apex is elevated from the diaphragm, what we call as a upturned apex, as you will see later. Whereas the LV contour is the apex is shifted down and out, rounding of the apex, not upturned, and an elongation. There is, if you look at the LV axis, it's an elongated axis, as you will see later. This very evidently, absolutely evident that this is an upturned apex, so this has to be a RV apex. This is of course not an RV apex, it is going down and below the diaphragm, so this is a left ventricular apex. So this is a RV apex, this is a LV apex. See, actually this is another very interesting X-ray. This X-ray actually is a case of a severe dilated cardiomyopathy with the heart occupying almost in the 6th space in clinical examination. But look at the upturning. There is an upturning of the apex, which may tell you, which may tempt you to say this is a RV apex. So you must remember that sometimes in big heart on the right left ventricle, the apex may appear to be a little upturned. So nothing is sacred in clinical medicine. And of course, you look at any particular contour, which we will see much later. Now we go to the atria, because we actually, this is like a pilgrim's progress, you know, our cardiac location, the situs, the size, the ventricle, and now go to the atrium. So right atrium enlargement, it is the main border forming structure on the right side. And you know, you have a prominent convexity on the right side, lower and lateral. A large diffuse bulge on the right. They are all very subjective. RA shadow occupies, this is the first time that there is something like an objective situation. An RA shadow occupies 2.5 spaces vertically in the right heart border. And the last one, which is totally removed from ground wall nowadays, is the RA border from midline. You draw a line from the midline to the RA border. If it is more than 55 millimeter or 40 millimeter in an adult or a child, it is called the RA enlargement, but that is now irrelevant. Why? Because our X-rays are coming as small X-rays. We don't have that huge X-rays coming up, small X-ray field and all. So this probably is not very important. But historically, this, I still remember reading it in the 90s. You must know it is an ancient print. This is 2020. So 30 years, it's a very long time for clinical medicine. This is a very evident, what I call as an undergraduate X-ray, where you have a huge bulge on the right side, occupying almost 4 or 5 spaces. So there is no doubt that this is a right atrial enlargement. Now you come to the left atrial enlargement. You are actually you must be much more familiar to this left atrial enlargement than me, because you are always dealing with a rheumatic heart disease and other cardiac illnesses. You have a prominent LA appendage which straightens the left heart border, elevation of the left bronchus if you get a good X-ray, widening of the carinal angle, and shadow on a shadow. It's a double shadow. These are all the 4 major things in a PA view. So you can see here the heart on the left side is more or less straightened, and here there is a shadow inside the shadow in an adult with a significant mitral valve disease. And this is again a shadow on a shadow with some imagination, but definitely LA appendage is definitely bulging towards the right. Now, what I found during my DM days is a small trick to know where the location of the LA appendage. What I used to do is I mentally drew a picture line from the aortic knuckle to the apex. Exactly at the middle will be the location of the LA appendage. So that is a very practical thing which you can use to decide whether are we dealing with a very prominent pulmonary artery segment or are we dealing with a huge left atrial enlargement. We have reached the atrium. Now we have to respect the great vessels. Aorta is an ascending aorta, can be a border forming structure on the right side, but it is definitely seen as an aortic knuckle at the top of the left heart border. And what are the abnormalities? What you expect is a dilated ascending aorta, prominent aortic knuckle, and very importantly in congenital heart disease, especially in a cyanotic heart disease, the arching of the aorta. Is it a right arch or a left arch? This I have shown you already a prominent aortic knuckle, because this X-ray, this patient had a bicuspid aortic valve without AS or AR, so it was a slightly dilated. You know that you have read that. You may even get a theory paper on aortopathies in children or aortopathies in adults, how to manage aortopathy. So many, lot of information, because many of them, and specific area is a post-operative congenital heart disease with aortopathy. It's a very important area people can ask you in the examination. Now, this is a very important point I want to tell you. That is, look at the pulmonary artery. You have the main pulmonary artery which divides into RPA and LPA, and RPA is further divided into an ascending RPA and a descending RPA. You must remember that the only pink ones are seen in chest X-ray PA view. RPA is not seen. RPA is actually it is what you call masked by the heart shadow basal. So you can comment only on MPA, LPA, and right descending and ascending pulmonary artery. What you say generally as RPA is actually the right descending pulmonary artery, as you will see later. You actually difficult to comment on the RPA. See, here is a situation where you know pulmonary artery is there, because below that is the concavity of the LA appendage location, and you can see the main pulmonary artery continuing as the LPA. The RPA is somewhere here, and this divides into a descending PA and ascending PA, and the RDPA is larger, much larger than the upper parts. So you should comment on an X-ray only on MPA, LPA, and RDPA, that is right descending pulmonary artery. And this is a huge pulmonary artery, dilated pulmonary artery, and you can see the width of the pulmonary artery segment on an X-ray, and again you used to be cut off like 16, 15 or something. So that is mainly for this one. When we say RPA, which means RDPA, not real RPA. And dilated PA can occur with PAH or without PAH, as you can see in Eisenmenger, idiopathic PAH and PAH due to any cause, whereas you can have a large PA in PS, IDPA, and absent pulmonary valve syndrome, which is a tetralogy variant. Next, we come to the pulmonary vascularity. 4 types: oligemia, plethora, so there's another term called pleonemia also, pulmonary venous hypertension, and of course, end stage of this will be a pulmonary edema. Now, you should remember that when you look for oligemia in a newborn X-rays, generally look oligemic, and you should be very careful in assessing the oligemia in a newborn X-ray. And the vascular shadows are of course reduced, and MPA, LPA, RDPA are smaller. This again a subjective feeling. Vascular shadows not seen in the middle part, only up to the medial part you can see the linear shadows. But you must remember this assessing oligemia and plethora in a chest X-ray. It all depends on what you are dealing with, a basic substrate, because if you give it to 5 clinicians, and there will be at least 3 different opinions, which we have already experienced even in a clinical discussion classes, etc. People will make their views maybe a little different. Now here, don't look at the heart, only look at the periphery. You can see there is absolutely no doubt that this is a oligemic field. You are going to see this X-ray again, but here the X-ray is only meant for looking at the vascularity. Hardly any shadows here. You cannot even see the pulmonary artery. So it is oligemia. Now look at plethora. Numerous vascular shadows. MPA, LPA, RDPA are bigger. Vascular shadows can be traced to the lateral zone. And the fourth point is very important in a good X-ray. The end-on vessel diameter is more, because they are more or less equal in a normal X-ray. If the end-on vessel diameter, which is a white round thing, it's more than the white with a cavity inside, it is increased. And more than 5 end-on vessel shadows on both lengths together would again indicate a plethora. So these plethora oligemia business, I think they are not very, what you call as very, very rigid. You should know whether it is normal or increased or decreased. Again, eyeballing is, I think it's very, very important. Here, of course, you can see there's no doubt that there's an increased pulmonary vascularity. Here again, especially on your left-hand side, you can see multiple end-on vessels. So this is pulmonary plethora. Now in adult practice, less in pediatrics, because we don't encounter much of pulmonary venous hypertension, but you do, and you know you have what you call as a beginning of this thing would be an equalization of venous vascularity, cephalization, and the lines, and of course the end, the pulmonary edema. Here you can see what you find as a little bit of cephalization going on, and you can even see that PA is little enlarged and all. And then you have here, this is, I must tell you that almost 90 to 95% of X-rays you are seeing now is from our hospital. Around 5% has been borrowed either from a person or from an internet. This is an internet. This thing only to tell you, you should know where the curly A lines and where the curly B lines are. As you know very well, you should know much better than me. Curly A lines are longer ones towards the hilum, and curly B lines are laterally shorter and indicate a pressure. So there is a general, is another exam question, the general feeling that if you have equalization of cephalization, the wedge pressure, the pulmonary venous pressure will be somewhere around 15 or so, 50 to 20 maximum. And if you have curly A lines, B line, what you call as an interstitial edema, it will be between somewhere around 20 to 25. And beyond 25 or 30, you will get a frank pulmonary edema. I think this is basically should be known. You should go back and exactly find out those values. This is again showing a pulmonary venous hypertension. So having done all these things, you should look at rib notching, either a unilateral or a bilateral. We'll come to that. Ductal calcification. And you know, calcified mitral valve, aortic valve, aorta, very important. Standard question asked, paper, this Takayasu arthritis X-ray, they will keep you, and you look at the heart and you will forget to look at the aorta. Aorta will have linear calcification. We remember that. LV aneurysm, very important. Your, what you call as area, pericardial effusion, calcification, and various prosthetic valve. Now, what we have is devices also, various kinds of devices and coil. Finally, how to read a chest X-ray. Again, there is a particular process, just like reading an ECG. That is chest X-ray frontal. If you are sure, you say PA or APU. Cardiac position, situs. Cardiomegaly. Cardiac contour, LV, RV, or sometimes it is difficult. You say, I cannot commit. Left atrium, right atrium, both. Aorta and PA. Pulmonary vascularity. Others, and sometimes classical, ergon type. But never ever jump and say initially the what you call as the eponyms. Eponyms comes much later. So this is how you take a care of an X-ray. Now this I will show you a grand painting that is King Lear in the Storm by an American painter, because usually Americans are not very good in painting. But this gentleman came to Europe, studied painting, and stayed there in Europe for his entire life. And this was a very good, I thought it was very nice. It's purely, there is no hidden agenda. It's only a very good painting. You can always go to the net and find out this. So this is the first part, what you call as the how to read an X-ray. Now we will discuss the case scenarios. And Nikhil, my friend, naturally must be acting as what you call as a moderator. At this point, if there are any specific queries, I will try to answer. And you must always remember that the cardiologists nowadays are not very good radiographers. But we will see. If Nikhil says move on, I will move on.
Yes, sir. Yes, sir.
I will move on. Thank you.
Any doubts other people are having at this point?
Having.
Yes. Sir, before going, any doubts any people are having? Sir, one doubt was there, sir.
Yes.
Like you showed one DCM X-ray, and so just wanted to ask, like, how will differentiate DCM with Epstein anomaly?
Yeah, we will come to that because we are now going to the case scenarios.
Yes, yes. So, okay, sir. Okay. So, sir, I'll tell you, sir. Volunteer, sir. Who will?
What?
Should I give you any volunteer, sir, to tell you like what?
Yes, exactly. Very good. You read my mind. So give me
Dr.
5 minutes.
Dr. Amira, you are there? Dr. Amira, she is a pediatric cardiologist.
Yes, Nikhil. Yes, Nikhil.
Yes,
you can start with the. Okay, sir. We can.
Then 2 more names.
Sir, we'll go one by one, sir. I'll just.
Okay.
Yes, sir. Dr. Amira, she's a pediatric cardiologist, sir, from Narayana.
Okay. So that must be. And now the first X-ray may be too simple for her. Let's see. So whenever you find a newborn who is absolutely asymptomatic and the pediatricians feel that the heart sounds are better appreciated on the right, you must always remember that it is very difficult sometimes to pick up dextrocardia in a newborn baby, because the newborn baby is just this very small and your stethoscope is much larger. So, but sometimes they feel that heart sounds are better appreciated on the right side. So when you do that, you should suspect a dextrocardia. So this, as Amira will tell you, is what it is, a dextrocardia with
Situs inversus, sir.
Situs inversus. So this is the one which is probably the least malignant, most benign. You have a mirror image dextrocardia, very clear. And another very practical thing I want to tell you is that when you are given an X-ray of a younger child, you start with this. You should say the heart is on the left side, the liver is on the right side. So it is a cytosolitis levocardia, and then you go on like that. That will be very appreciated, especially when a child below 5 years, or you are dealing with a congenital heart disease. Even in an adult population, it is always safer to say that is you will get at least a partial portion of an abdomen in your X-rays. So these are the 3 practical points in defining what is a true dextrocardia, which could be asked. 1, major heart shadow to the right. Base, this is the term used by Perloff. Base to apex direction is to the right. And corresponding dome of the diaphragm is lower to the apex. Sometimes it is very difficult. They are almost at equal level, but generally it is on the lower side. So based on this, you can make a diagnosis of a dextrocardia. This we know that. Now this, Amira, is is a
There is a cytosolitis dextrocardia, sir.
Yeah, correct. See, actually, in examination for a student, you should start with the location of the heart. So you should start first dextrocardia with cytosol, and you can see the 3 points. Heart on the right, the base to apex axis is very clearly towards the right, and I agree that the diaphragm levels are more or less same. It is very difficult, so that is plus minus. So this is a dextrocardia with situs solitus, where you expect 90% of them should have some sort of a cardiac problem. And this is of course a midline. Now I will show you another X-ray. You concentrate on this X-ray. This of course shows the middle part. But I want you to look at this, for maybe all of you to look at the X-ray for around, let's say, 10 seconds. And I will ask you one question. So you have seen this is a midline heart. This is also a midline heart, right? Now, what is peculiar here?
Liver shadow, sir.
Yeah, that is the point. So, exactly, precisely. So this is a very interesting X-ray where you have both sides. You have the liver, what we call as a midline liver. Whenever you have a mesocardia, cardiac malposition. See, another thing you must understand that in real life, most of the so-called mesocardias which you come to for evaluation are usually normal, generally, because it's only a slight positional change. But this has to be abnormal because you have a midline heart, which means that you are dealing with a ambiguous situs, that is what you call as an isomerism, which can be on the right isomerism or on the left isomerism. So this could be a potential X-ray for your OSCE. So you must go back, learn about isomerism, because there are two terms, American term and the British term. British term and isomerism. Americans term it as polysplenia, asplenia. One gentleman is Richard Van Praagh on American side, and this side is Anderson. So you should know which on which, and what is the general difference between right isomerism and left isomerism in congenital heart disease, because all of them would have some sort of a congenital heart disease. Can I ask you, between right isomerism or left isomerism, which one will live longer? Anybody?
Left isomerism, sir.
Left isomerism, because the right isomerism was described by Mark will die by around 18 months. There nobody, if some baby lives beyond 18 months, it is most likely not a right isomerism. They don't die of cardiac problems mainly, they die of severe fulminant infections. And they can ask you one OSCE, that is, if you have a Mark syndrome, what simple investigation, very simple clinical investigation which will help you. What is that?
Peripheral smear.
Peripheral smear, looking for a Howell-Jolly bodies. This is another X-ray which again shows a dextrocardia with a situs solid. Look at this X-ray, and what is your comment on this? Unfortunately, the site is not marked, but I tell you, on your left hand side is the right, and on your right hand side is the left. So I assure you that is that. So what is happening here? Where is the heart mainly? Is it in the middle? Exactly. So the heart is primarily on towards the left side, and the liver is to the left, and the stomach is on to the right. So it is a situs inversus liver, or you call it as levocardia with situs inversus. They always say exactly. This is one child. Actually, this child I remember distinctly because this child had a 3/6 apical pansystolic murmur with arthralgia. ESR was some 36 and all, and we diagnosed what we diagnosed. We expected a rheumatic carditis with moderate MR, right? And actually, The PR interval was also prolonged, 220 million. I still remember this X-ray. That is why I kept. I think this kind of X-ray I don't have much. So we diagnosed the rheumatic. We actually started on aspirin because there is some delay in taking an echocardiography, and echocardiography was totally surprising. I mean, we are surprised, and then only we realized that we have not looked at this X-ray very carefully. Maybe we are carried away by the ESR, polyarthralgia, and ECG. So what is this again? What? Levocardia with the situs inversus. What is the most likely congenital heart disease in this patient?
CCTG.
Exactly. CCTG. So you must remember that if you have a dextrocardia situs inversus, the kind of TGA will be very small percentage of 5% will be DTGA. Whereas 40% of heart disease, in especially cyanotic heart disease in a situs solitus dextrocardia, will be congenitally corrected transposition, whereas majority of heart disease in this picture, because at least I have probably over the last 20-30 years I have seen 4 or 5 levocardia with situs inversus. All of them happen to have a congenitally corrected transposition. Some of them had presented only with MR, one had presented with a large VSD-like presentation. 2 of them had a tetralogy-like presentation. So this X-ray you keep in your mind. Anyway, I will be sending this to Nikhil, cut into various pieces, right? So this will be the most likely diagnosis, is a congenitally corrected transposition. So you must, postgraduates especially, we must be very thorough with 2 anatomical, apart from tetralogy and TGA, of course, LTGA and Epstein, because they are exotic lesions, and the examiners are very fond of these 2 congenital heart disease in terms of various aspects, not only X-ray, ECG, echocardiography, catheter, pressure tracing, all those things, very, very important condition. Now, this is another dextrocardia. Can anybody tell any additional points? This is a dextrocardia with situs. Situs?
Situs inversus.
Situs inverse. So you expect the heart disease likelihood is only 5%.
5%.
5%. What is there extra here? This is the reason why I told you, after seeing the heart, you must look at the lungs and the ribs and etc. etc. Look at the lung. See, suppose your right hand side is the one lung. So what is that lung morphologically? Is it a right lung or a left lung? Morphologically?
Right lung, sir.
Right lung, because it goes with the liver. There is a visceroatrial concordance. So the right lung has how many lobes? 3 lobes. This will have a 3 lobe and this will have only 2 lobe. So what is happening to the middle lobe of the left-sided right lung? There is a middle lobe pathology. You agree with me? There is a definite middle lobe pathology, because normally we don't say middle lobe pathology in that X-ray because that lung will be morphologically left lung, but here it is a morphologically right lung. So if you have a dextrocardia with situs inversus and a middle lobe lung pathology, what will you think of? Any syndrome? Cartagena syndrome. Cartagena syndrome can be there. So this is most likely a Cartagena syndrome. Now we have another. I want another volunteer, Nikhil.
Yes, sir. Sharon, ma'am, can you take that, please? Hello.
Sharon.
Yes.
Yeah, Dr. Sharon is a faculty or student?
No, sir. No, sir. Nothing. No, sir.
Okay, you're being very respectful. Very good, very good. We must always be respected. What we used to call as the weaker gender, but now they are more powerful. Anyway, now you have a 17 days old newborn who is symptomatic with deep cyanosis. So you have a 17 days old newborn with deep cyanosis. Naturally, we know the 3 possibilities are primarily DTGA or a pulmonary atresia with a VSD or something like that. That is, that 2 weeks, within 2 weeks, your symptomatic deep sinus baby will have this. So now you read the X-ray. But Sharon?
Sir, chest X-ray, APU.
APU.
Levocardia with situs solitus.
Very good.
There's a gross cardiomegaly.
There is a gross cardiomegaly.
Increased pulmonary blood flow.
Before that, you want to look at the atrium, the ventricle.
Apex looks LV morphology.
LV. It is upturned apex, definitely an upturned apex. There is a big angle between the diaphragm and the heart. So that is more likely to be an RV apex. Any atrium? Right atrial enlargement is very prominent. So you have a right ventricular enlargement, a right atrial enlargement. Then what else? Is an increased vascularity. So you have a newborn baby with the deep cyanosis. 3 possibilities are there: TGA, pulmonary atresia, and tricuspid atresia. So with this X-ray, you will move towards. With this X-ray, you will move towards DTGA. So you should look for a DTGA because everything is there for the DTGA. This is actually what we call as a egg on side appearance. For example, you have 5 points are there. You should know that you should tell. That is, 1 is, as she said, cardiomegaly. Number 2, RV apex. 3rd, right atrial enlargement. 4, a relatively narrow base or a pedicle, and lastly increased vascularity, because regular DTGA with intact septum is a heart disease with either normal pulmonary blood flow or increased pulmonary blood flow. It's a very interesting situation. So 5 points you should remember: 1, 2, 3, 4, 5. Then only you should say this has an egg on string appears, because as a medical scientist you should go by specific findings and then only give a particular name for that. And this is another X-ray which again is a DTGA with a huge right atrium and more or less like a slightly malnourished egg, perhaps, compared to that. And this is called as an egg on string or an egg on side appearance, which of course is an important point. And again, for your knowledge, it takes at least 2 weeks. That is very, very important for a DTGA to look like an egg on side appearance. Minimum 2 weeks is required. Now that is very important because 20 years ago, TGA used to come to the hospital on this first month, second month. Then we used to get these X-rays. Nowadays, you don't have an X-ray. For the last 5-10 years, I have not got a single TGA with an egg on side. Why? They come very early, first day, second day. So that is basically because of our improvement in providing health care to our children. So all these X-rays of a DTGA of mine are pretty old or ancient. This was another DTGA which looked like egg on steroids, big one. And this was a dextrocardia with situs inversus. See, if you have a dextrocardia with situs solitus, most likely TGA will be LTGA, congenitally corrected transposition. And this was an interesting situation where you had actually DTGA in a dextrocardia with situs inversus, which will behave like our own pattern. Next, my friend.
Yes, sir. Before that, some doubts, sir.
Yes.
Sir, you told something 3 causes like TGA, tricuspid atresia, and pulmonary atresia. I didn't get, sir. What you are saying, sir? These 3 conditions.
Yeah. See, the point is, first thing is, that the most common congenital cyanotic heart disease in the newborn is DTGA. That is the only exception. Otherwise, at any point of time in life, tetralogy is the most common cardiac problem. So that has to come first. Any blue baby within 14 days, first you should always think of a DTGA. That is number one. Number two is pulmonary atresia, which is a duct-dependent lesion. And this pulmonary atresia can be with VSD or without VSD. If you have no VSD, you call it as a hypoplastic right heart syndrome. The third is tricuspid atresia, because 70% of tricuspid atresia will become blue by 1 week. 99% of tricuspid atresia will become blue by 1 month. So first 14 days, these four conditions are there. Number one leading is DTGA. We have our data in our hospital, SAT hospital, Pediatric hospital. For the first 2 weeks, number one is DTGA, closely followed by pulmonary atresia with a VSD, which we call as a tetralogy with pulmonary atresia. Third was actually tricuspid atresia, and fourth was pulmonary atresia with intact ventricular septum. These are the common conditions. That is, basically, you will have atresia and a parallel. You remember like this, 3 atresias and 1 parallel circulation. That are the most common causes of cyanotic heart disease before, let's say, 2 weeks. Of course, there is a condition, obstructed TAPVC will come very sick and cyanosed, but that is always there, but that also can be probably included. So you can make it as a 5 major conditions which come with blue color in the first 2 weeks of life.
Okay, sir. Okay. Yes.
Sir,
No.
it's kind of situs inversus and this dextrocardiac combination that DTGA is common, sir. Like DTGA is common and LTGA common. You told some combination, no?
Actually, levocardia with situs solitus, right? Exactly. And the mirror image is what? Dextrocardia with the situs inversus, right?
Yes, sir.
Agreed. So in that situation, you expect only common conditions, not complex conditions. That is why you remember. So among complex condition, which is the usual TGA, which DGA is there? DTGA is there, because DTGA is perhaps the second most common congenital cyanotic heart disease. So that, whereas if you have a dextrocardia with situs solitus, there is a disparity. There you expect a LTGA. This is a usual question asked in the examination. I'll give you an example. If you get a short case of a cyanotic heart disease in an older child who has a dextrocardia with situs solitus, good murmur and a single second sound, all you have to say in the examination is that, so this child has a congenital cyanotic heart disease with reduced pulmonary blood flow with dextrocardia with situs solitus, and clinically is behaving like a tetralogy of Fallot. So the immediate question would be, if you get a tetralogy-like presentation in a dextrocardia with situs solitus, what actual disease that you expect? And you say, ma'am or sir, it is a LTGA, VSD, PS, because 40% of this important heart disease is LTGA in situs solitus dextrocardia. Whereas situs inversus dextrocardia, it goes with our common pattern. That is, most likely cyanotic heart disease is there is tetralogy. The second most likely is DTGA. Then you have DORV, etc., etc. So that is how. So very what you call as exotic lesions are more common in situs solitus with the dextrocardia. Am I clear?
Okay. Okay, sir. Okay.
Now, another newborn, we want another young person to travel with me.
Yes, sir. Krishna is there? Krishna? Dr. Krishna? Hello?
Hello? Krishna is there?
Dr. Bhushan?
Yes, Nikhil, I'm there. Yes.
Hello?
Yeah.
Hello?
Yeah.
Yes, sir.
Yeah.
Bhushan is here. Bhushan, this is another newborn. Again. Hello?
Sir, yes, sir, I'm able to hear you, sir.
Yeah. This is another newborn, symptomatic. And here again, deep cyanosis. So previously we had a newborn who was symptomatic and had deep cyanosis, but hardly any murmur. Now here is a very good murmur. So this is again not only X-ray but also in clinical examination. This also is very important. So deep cyanosis, a good murmur, and you have an X-ray like this, which you have seen already.
Yes, sir. This is the chest X-ray AP view, sir, with
Right.
situs solitus with levocardia, with
Yes.
a cardiothoracic ratio of around 0.5 or more than 0.5, sir. With
Yeah.
RV type of contour, sir. Apex looks upward.
Correct.
With RV type of contour, and there is RA enlargement there, sir.
Precisely.
Yes, and there is pulmonary bay is there, and oligemic fields are there, sir.
Right. And if you look at it very carefully, you will also find this also looks like an egg.
Egg on, yes, narrow
egg on side. But what is the major difference between the previous X vascularity is very much reduced.
Yes.
So you can it's a DGA with correct. Yes, exactly. Because this has to be behaving like a severe tetralogy of Fallot, TGA VSD pulmonary stenosis. So that is the major difference between the previous X and this particular X-ray. So DTGA VSD PS is a one which will have a, this was actually a DTGA VSD PS, and that is the correct thing. And this is the way you to do it. That is chest X-ray, AP view, levocardia, situs solidus, because you get an abdominal portion also there, mild to moderate cardiomegaly, RV contour, RA enlargement, and pulmonary oligemia. And of course, with all this, then you can always, very safe to say, base of the heart or pedicle of the heart is little on the narrower side. No harm. Yes. See, another point is that,
narrow pedicle, sir?
There is no criteria. It's only a visual thing. There is not much of no criteria. Now this is another X-ray of an older child. Actually, this child was an unfortunate in the sense that this child had a DTGA, was not operated, and mainly because of they refused to operate. My child came very late, like he was around 12 or so, and this is actually a DTGA. BSD PH situation, and when it got Eisenmegerized naturally by 12 years, naturally they would get Eisenmegerized, and because they got Eisenmegerized, they lived. This child lived. But look at this X-ray. I don't think nobody will diagnose a DTG in any this X-ray. Agreed? No. So this is not what I said was, many times clinical medicine is a very difficult process. You have an exam case, discuss everything, make a professional diagnosis, you show an X-ray, and that X-ray may not correspond to your physical findings or whatever. So that has to be accepted. Many times when there will be discrepancies between what you think is the heart disease and what you get, especially in an X-ray. In that way, more dependable would be electrocardiography. That is why whenever you deal with a cyanotic congenital heart disease in the examination, and the examiner wants you to take either ECG or X-ray first to discuss, you always take which one? Electrocardiography. Now, Bhushan, it's another baby, 65 days old baby, 2.5 months old, symptomatic with heart failure, with mild cyanosis. So, you have a 2-month-old baby symptomatic with heart failure, with a mild cyanosis. What we are thinking is a admixture lesion, at the atrial level, at the ventricular level, or the great vessel level. Very simple thing. So, what is this level? Is it atrial level, ventricular level, great vessel level?
Sir, this is a chest X-ray. Sir, looks like AP view, sir. Its lips are more horizontal, sir.
Exactly.
Yes, sir. With
the levocardia with situs solitus.
Yes, situs solitus with levocardia, sir. Apex could not be commented, sir. It looks like a normal apex.
Yes,
sir.
Absolutely correct. Be honest, correct.
Yes. With RA enlargement is there, sir. With there is like figure of 8 appearance, sir. With on the left upper border there is dilated SVC, sir, and on the right upper border there is vertical
you presume. You don't read it, no? You don't say it's an SVC. You say there is a figure of 8 appearance. There is a shadow. So most likely would be a
supracardiac TAPVC.
Supracardiac. What else? One more word, adjective.
So it is a heart failure, obstructed type of supracardiac TAPVC.
Obstructed TAPVC, you will not get such a dilated vertical vein and all, no? So maybe partially obstructed. That is why the heart is not very much enlarged. So you must specifically say supracardiac TAPVC with or without obstruction. Here it's likely to be with the minimal obstruction. So you must remember, physiologically, all TAPVCs are physiologically, there is some sort of obstruction. If you get a very severe obstruction, you call it as obstructed TAPVC. Inherently, my master teachers used to teach me that all TAPVCs are inherently a little bit of obstructive. So this is a figure of 8 appearance, classical appearance of an obstructed or unobstructed supracardiac TAPVC. And this is, we also call it as a what you call snowman appearance. You know, Americans are very fond of this snowman appearance. This is another X-ray, and this is, we call it as a figure of 8 appearance. I probably can bet that nobody knows this particular comic character, no? Mandrake. When we were very young school children, we used to have Phantom and Mandrake. Now you have Avengers and all those people. And there was a big organization called the villain organization called the 8. So what I want to know from Bhushan is the constituent. Anyway, I have given you the slide. The constituents you should say on your right hand side, RA and SVC, dilated SVC, and on your left hand side it is vertical vein, and this is the vertical vein, and this would be the ventricle. Which ventricle, Bhushan? Likely?
Sir, it should be RV, sir. RVC.
RV. But RV has to enlarge so much, no? And RV has to enlarge so much to cross the LV. So it is sometimes very difficult to design. So I have at least when we were very young and hardly any internet and all, we used to search many books to see whether it was RV or LV. But I have a feeling that it is still LV anyway. And another thing you should notice is that the upper half of the 8, the shadow is not as white as the lower half, right? You see that? Because both are venous channels, they are less dense. This is very important when you come to another practical problem in pediatrics, where you have a figure of 8 appearance, because that could be also due to the thymic enlargement. So this is a true thymic enlargement, and you can see the difference in density. Everywhere the density is the same, not like our regular TAPVC, which you have seen here. Right? That is a very practical point. This was another TAPVC. Now another person, another gentleman or lady.
Sir, Krishna is there. Krishna.
Yes, sir.
Krishna, are you there? No, and he's not there. Sohail?
Sohail?
Yes, I'm there.
Yes. This is a 3-month-old baby who is symptomatic with a respiratory distress. There is a genuine, and there is again a tinge of cyanosis. So when you have distress means heart failure, tinge of cyanosis means cyanosis, desaturation. So you have a heart failure in a 3-month-old baby with a tinge of cyanosis. This is a very difficult X-ray. So, and this actually we made the diagnosis retrospectively. But just see what does this X-ray show?
So chest X-ray, sir, AP view overexposed, sir. Situs solidus levocardia.
Correct.
There is a LV type of apex with likely RA enlargement is there, sir.
Yeah.
And
what is the location in the heart? Where does it? Is it mainly towards the left or middle, or does it take a middle pathway? Somewhere in the middle, no? somewhere. Anyway, somewhere. But primarily, I will say maybe towards the left. Okay.
Yes, sir. And there is also splaying of carina, sir. The carinal angle is wide, and apex looks LV with RA enlargement, LA enlargement, and a wide carinal angle. So RA enlargement with LV apex, I will go with tricuspid atresia, sir.
Okay, but the vascularity, you look at the vascularity, normal, no? Everywhere the vascular shadows are there. Now, what happened was this chest, this is a very interesting X-ray which makes people very humble. This X-ray was taken for a respiratory distress with fever, cough, pneumonia. The clinical diagnosis was a pneumonia on the right lung, and we took an X-ray and we thought, okay, very good, this is a middle lobe pathology. We never thought of a major heart disease and all. There is hardly any murmur in this particular baby, and was not improving. There was a desaturation, mild desaturation. That is why we took this child for an echo. Otherwise, we would not have suspected an echo.
Transverse liver also, sir. Transverse liver and
exactly, almost transverse liver. So there is some problem with this. Some sort of heterotaxy, maybe. But what we thought was this diagnosis was made only after the echo. So echo showed basically a hemi-anomalous pulmonary venous drainage into the inferior vena cava. So what was that basically? What syndrome? Scimitar syndrome. So this was actually Scimitar syndrome. So there was definitely CT showed definitely a mild hypoplasia of the right lung, and the heart I told you was midline. And if you see this probably could be when in retrospect, this must be that sword. No, that is the common pulmonary vein draining into the IVC somewhere here at the level of the diaphragm. Because usually in a hemianomalous Scimitar syndrome, the right lower and middle lobe will drain primarily through a common pulmonary vein into the IVC at the level of diaphragm, and the other one can drain either into the IVC or directly into the LA. And because the lung is usually sequestrated and slightly hypoplastic, what will happen is that the heart will move towards the right, so it will have a midline. But basically, this will not be kept in the examination, very difficult. But you should know that this kind of thing exists, and you can see on your left hand side very clearly a sword-like thing going and becoming wider. I think that is a very practical point you should know, because if it's a simple vessel from the hilum towards periphery, towards diaphragm, the width should be less, no? Here the width is more when it enters and it reaches the lobe of the diaphragm. So this was a Scimitar syndrome. So you should know the physiology of the Scimitar syndrome, because two conditions, TAPVC and this thing you should know as a postgraduate, not only X-ray, but NDT and management and all. Then I think louder.
Sir, it will be SINOT.
This is no, because this baby had severe pneumonia also in between, so it will be an acyanotic condition. So basically an acyanotic situation. But what happens is that there is a sequestration of lung. Invariably, the patient comes to pediatrics with a pneumonia. So saturation will be somewhere on air will be around 91, 92. So we will suspect a congenital cyanotic heart disease. That is what has happened. So, but what we thought at that time was basically pneumonia and the middle lobe collapse consolidation. We were thinking of a genuine pneumonia and something like that. Sohail, I think Sohail can continue with this also. Now, this is a 15 days old baby who is symptomatic with significant cyanosis, 2 weeks. So, you know, which are the conditions, right? You have TGA, pulmonary atresia with VSD, without VSD, tricuspid atresia. Only 4 conditions, and a TAPVC obstructed. These are the 5 conditions maximum you can go. So this X-ray is very simple X-ray. You read this X-ray.
The chest X-ray, sir, AP view. Overexposed film, situs solitus levocardia, sir, with RV type of apex.
Good.
And there is left aortic arch, and there is oligemia of the lung field, sir.
And there is some, if you have imagination, you can even put it as a mild concavity on your left heart border.
So pulmonary
Base little, yeah, empty. So this is most likely. These are all, everything can be most likely only. It is most likely a tetralogy of Fallot. The only point is that this baby came at 15 days. So usually it was present somewhere around 3 months, 2 months. So this basically was actually a pulmonary atresia with a VSD, what we call as tetralogy with a pulmonary atresia. But this is almost a typical X-ray. And you know this, what we call as a coronal sabo finding. This is another X-ray. Here I think very prominent thing which you see is the bay, no? That pulmonary bay is absolutely empty. So one interesting point is that if you don't see a good pulmonary artery segment at the expected position, what you should know is that 3 possibilities are there. One, pulmonary arteries are small, like in tetralogy, all those things. Or pulmonary artery is behind the aorta, like in a transposition of great vessels. Or pulmonary artery is arising from a major truncus, like a truncus arteriosus. So truncus arteriosus is one condition where you don't see the main pulmonary artery prominently, but increased vascularity. And again, tetralogy with extensive MAPCA will have vascularity will be very much increased, but you cannot see the pulmonary artery. So the pulmonary artery, lack of pulmonary artery at the pulmonary bay location is either due to a small pulmonary artery, a posterior pulmonary artery, or a pulmonary tetralogy, but just to show you the right arch, and you should know very clearly that the truncus has the highest percentage of right side aortic arch, ranging from 30 to 50%, half. Pulmonary atresia with VSD is 30%, standard answer, and 25% is pulmonary tetralogy of Fallot. And if you look at right side aortic arch and a congenital cyanotic heart disease, hardly any congenital heart disease without a VSD will have a right arch. So there is some link between a sort of an ESP between presence of a VSD and presence of a right side aortic arch. So much so, DTGA with intact septum has hardly any percentage of right side aortic arch. And this arch is it used to be a very important sometime earlier for a tetralogy. Anybody know the reason why this is important?
Classical VT shunt.
Yes, exactly. Very good. Because technically it is difficult to do a classical BT shunt on the same side of the arch of the aorta because of a mirror imaging of the branches. So you should always used to do it in the opposite side. Nowadays, hardly any classical BT shunt is being done, as we know very well. It is only the modified, so you can choose either side to do a modified BT shunt. And secondly, when you have a tetralogy with a right side aortic arch, you can think that, okay, maybe it is probably more like a pulmonary atresia situation. That is the importance of this. Another person, another gentleman or lady.
Yes, sir. Krishna, you're there. Audio, is it okay?
Hello. Yes, are you able to?
Yeah, Krishna, because this is like Krishna is like Scarlet Pimpernel. Now we seek him there, we seek him here. So you are now found out. So very good. This is an older child. Okay, no problem. No, just joking. It's an 11-year-old boy who is symptomatic with functional class 2 cyanosis. So this is very interesting because this is not only for X-ray. I tell you, when you find, I don't know whether I have told you previously in the class, whenever you find a child beyond 10 years with cyanosis in the exam setting or real setting, you should know there are only very few conditions who will survive at 10 years. Now, tetralogy is number one. Eisenmenger is another one. Epstein is another one. LTJ is another one. Single ventricle PS. These are the 5 important conditions which would survive beyond 10 years. So one of this must be here. An 11-year-old boy, symptomatic functional class 2 with a tinge of cyanosis, mild cyanosis, saturation at 89 or something. Very, very classical X-ray.
This is a chest X-ray PAVC.
Yes.
Situs solitus leocardia with CTR ratio is more than 0.6 with
more than 0.6 or even more than 0.7.
Yes, 0.7.
So it is a massive cardiomegaly. Right.
Massive cardiomegaly is there. With looks like LV type of apex with RA enlargement, and there is oligemic lung field.
Exactly.
With, left aortic arch and yes,
correct. You're right. Very good. Then what else?
Sir, this could be
any other finding? Any other finding?
Sir, infundibular enlargement is there. Sir.
Yeah, but that is you are presuming, no? Because your likely diagnosis is an Epstein. So naturally, we want to presume that an RVOT is dilated. But if you look at the base, real narrow base, base is relatively narrow on oligemic. So critical is narrow. So this is most likely, as you said, is an Epstein anomaly. This is a typical Epstein anomaly. And what you are absolutely right. What we thought, what we think as a you have this area which usually occupied by the LA and dot is actually occupied by the RV outflow tract. That is why it is very prominent, sort of a straightening thing, and the huge ballooning of the right atrium with pulmonary oligemia, very clear-cut oligemia. So this we should take it as a most likely an Epstein anomaly. And Nikhil was asking, how can you differentiate between a what pericardial effusion or DCM? DCM. Nikhil was asking me previously how to differentiate between an Epstein versus DCM in a when you get a large X-ray.
DCM will get pulmonary venous hypertension.
Exactly, precisely. We will get a pulmonary venous hypertension will be definitely there, and the base may not be as narrow as this. And see, whatever sudden then DCM is a disease of primarily it affects the left side. So you don't see the huge bulging of the right atrium in the in a dilated cardiomyopathy. So that these are the findings. It's an Epstein anomaly, and I will tell you that one very important test we used to do when we are DM postgraduates, we used to simultaneously record the ECG and pressures of RA, atrial-laced RV and RV, and to show the difference, which is still explained in Moss Adams. You must go back and read about that 3 types of tracings. Simultaneously reading ECG as recording ECG and pressures at 3 levels and making a diagnosis. That's a very, very interesting question and an answer. Because Epstein is going to come as an examination case, not only as a primary Epstein, secondly as a post-Glenn Epstein also will come to you. So you should be very thorough about the Epstein anomaly. And this is an Epstein anomaly. And this is another Epstein which we had in our hospital. This was actually Dr. Krishna Kumar from Kochi, Amrita gave me this one. This is our own Epstein anomaly, and this is also called a box-like heart. See, whenever you describe all this in eponyms and all, you should have some little bit of imagination, that's all. And this was another infant with a very huge heart, almost 80% cardiomegaly in a very sick Epstein. And another practical point is that if you find a huge heart in a chest X-ray in a newborn, think of Epstein anomaly first, critical pulmonary stenosis, and intrauterine myocardial inflammation. In an infant, again Epstein rules, followed by severe critical PS, dilated cardiomyopathy, pericardial effusion. In a child, Epstein, DCM, pericardial effusion, and slowly in India, mitral valve disease also very important. These are the conditions which we have seen as having huge heart in a chest X-ray at varying ages. Krishna, we'll have one more question to you.
Yes.
11-day-old baby, symptomatic deep cyanosis. So you know DD, 3 DDs only, right? Tricuspid atresia, pulmonary atresia, and the transposition of great arteries.
Sir, this chest X-ray AP view, sir. It's a situs solitus levocardia. It's an underexposed X-ray with RV type of apex, with CTR ratio is around 0.5.
Maybe a little more than 0.55.
Yes.
Okay. Anyway. So there is not much of cardiomegaly.
Yes, sir, not much cardiomegaly with empty pulmonary bay and oligemic lung field, sir.
Exactly.
With RA enlargement is there, occupying more than 2.5 intercostal space.
Yes. So this X-ray is a cyanotic child oligemia with a pulmonary bay. And we had seen a tetralogy X-ray also, pulmonary bay oligemia. What is the major difference between that X-ray and this X-ray?
Here, sir, ascending aorta looks dilated, sir.
Okay. What else?
So reticular pattern is there on.
But atrium, see, atrium is practically absent in a tetralogy of Fallot. Here there is a right atrial enlargement, right?
Yes.
So we have 3 diagnoses: TGA, tetralogy severe, tricuspid atresia. Now which will you choose?
TGA will have a right atrial enlargement, sir.
But not but it is not like looking like no. And there is no narrow pedicle.
With PS, sir. With
PS, you should, okay. But actually, this happened to be a tricuspid atresia. So we thought of tricuspid atresia mainly because of a significant right atrial enlargement. But now you will find the apex is little upturned. You know, you have seen that. You have noticed RVF. That is why you never thought of a tricuspid atresia. So sometimes we do see this when in a tricuspid atresia, sometimes the apex sometimes may appear like this, which will lead you far away from your diagnosis of a tricuspid atresia. This is again to convey to you that not everything is picture perfect. You know, you can have much variation. You can. I will come to another X-ray, then you will realize some X-rays can totally mislead you. But this ECG was very classical of a tricuspid atresia. So we made a pre-echo diagnosis of a tricuspid atresia with a VSD pulmonary stenosis. Another person, another friend of mine. Because
sir.
Yeah.
Yes, sir. Dr. Radha, you are there?
I'm here, Nikhil.
Yeah, good. Nikhil, Radha is there. This is a 1-day-old baby, day 1, symptomatic, severe respiratory distress and cyanosis was referred for a evaluation. And you find a very, very, very important X-ray, not only for the baby, not only for the doctor, but also for postgraduates, because this can be kept in the exam.
This is chest X-ray, sir. AP view, ribs are horizontal. Looks like mesocardia, sir.
Okay.
In this, I can't really tell about the solitus. It's
Sometimes difficult. Very good.
And more
whenever
like
you have a midline heart, you must be little careful, no? Because the situs may be little abnormal. Okay, doesn't matter. Good, very good.
And looks like base to apex is towards the left side only, sir.
Yes, so most likely it is a levocardia. Anyway, okay, right, very good, super.
So there's no cardiomegaly. CTR looks
exactly, precisely. See, you have a distressed 1-day-old baby without a heart cardiomyopathy. Very good.
And looks like, sir, severe pulmonary venous hypertension.
Exactly. So you have reached the diagnosis. What is the diagnosis?
Obstructive
exactly. So, because seeing this X-ray, you must have seen this X-ray before, somebody at least, but never get tempted to say obstructed APVC. You say as Kranatha was saying, chest X-ray, AP view, situs difficult, midline heart, but basically apex pointing towards the left with no cardiomegaly and severe pulmonary venous hypertension. Most likely diagnosis would be an obstructed TAPVC. And you must remember that I still remember these are all grand olden days before you were born. In 1987, I read a PCNA article saying that possibly the only heart failure in infancy and childhood where there is no cardiomegaly is an obstructed TAPVC. Now I want you to tell me other situations, cardiac situations, which can come with severe pulmonary venous hypertension in the newborn. There are very rare conditions. Logically, louder. You are right. You may be right. Any inflow obstruction. Coat right, correct. Coat right. Mitral, congenital mitral
atresia.
Mitral stenosis, congenital mitral stenosis, and mitral atresia. Exactly.
Hypoplastic left heart.
Yes, that. But they have some cardiomegaly. Then pulmonary vein stenosis. So these are conditions. But in pediatric postgraduate, they will always think of a hyaline membrane disease. So I will show you one hyaline membrane disease. This is what we call as a what is it called? Whitewashed lung. You will find it's very. Sometimes it is very difficult to distinguish between obstructed TAPVC and HMD, that is idiopathic respiratory distress syndrome, and the only person who can help is an echocardiographer who will tell you that this is this and this is that. And you know also it's very difficult to diagnose obstructed TAPVC, especially if it's an infra diaphragmatic, very difficult to because it's actually a challenge to a young pediatric cardiologist. Then Radha, one more question to you. Simpler. Okay. 7-year-old girl, asymptomatic murmur. So naturally, you would think of a simple lesions. You tell me the findings.
Sir, chest X-ray, it's a PA view, sir.
Yes.
Levocardia, no cardiomegaly.
Situs.
Situs solitus. LV apex, sir.
Yes.
And pulmonary artery looks slightly prominent, sir.
No. Chamber. Atrium, any atrial abnormality.
So right atrium mild enlargement is there.
Yes, there is a right atrial enlargement. Agree. Correct. It occupies 3 spaces.
Yes, sir.
You have or minimal cardiomegaly. You have a right atrium. It's a left ventricle apex. And what about the right atrium? Is there great vessels?
Sir, RPA looks slightly dilated, sir.
RPA means RDPA, that is right descending RDPA dilated. MP also looks
dilated. So probably atrial septal defects.
Defects. But one point which you said was against this is you said it was an LV apex because you told there was a good angle between the. See, that is what I said. When in doubt, it is very clear RV apex, you say RV apex. If it is very clearly LV apex, you say LV apex. Otherwise, just keep silence. So a minimal cardiomegaly, right atrium enlargement, and PA enlargement and increased vascularity, you should possibly think of a pre-tricuspid shunt. It is a most likely an atrial septal defect. That's all. This baby, another person, another gentleman, Nikhil or Nikhil. Let's see. Let's have Nikhil for a change. Nikhil, are you ready?
Yes, sir.
This is a 7-year-old. It's a 7-year-old girl symptomatic with a BP of 140/40. So diagnosis, you know. What is the diagnosis? In our OPD setting.
No.
We're talking about 7-year-old young girl.
PD,
PDA, most likely a patent ductus arteriosus. Most likely.
Yes.
And this is an X-ray. So what is happening here?
Yes, sir. So basically, this is a chest X-ray PA view, sir. And then there is a situs solitus is there. Cardiomegaly is there, sir.
Yes.
And coming to the borders, left side, we have there is a come first to chamber, sir. It is a LV, looks like a LV type of apex to me, sir.
Correct.
Yeah, sir. Then coming to LA, I don't think it is enlarged. RA also is not enlarged. Then pulmonary artery is enlarged, sir. So
what about aorta?
Aorta, sir, it is left-sided aorta only, sir. And
okay, is it large or normal or?
Yeah, sir, it is large, sir.
Little prominent, no? It is prominent. It has a large pulmonary artery. Here there is more or less some sort of imagination straightening can be found out. But anyway, it is a large heart with pulmonary plethora with a prominent aorta. Well, that's a very important point in a post-tricuspid shunt. If you have a prominent aorta between VSD and PDA, PDA is more likely. But let me be very honest with you. In many of the situations, this is very difficult clinically to distinguish between an X-ray of a moderate VSD versus X-ray of a
PDA.
PDA sometimes, but this is an X-ray. This is another X-ray, which again this X-ray could be actually this X-ray was that of a PDA, but it could be also due to a large, moderate to large ventricular septal defect. But here you can see this was actually a moderate PDA with straightening, right? You can straightening of the left heart border, which meant that it is most likely a PDA. So this is a pre-tricuspid shunt which you have seen already. This is the post-tricuspid shunt with a large VSD. Everything is there, vascularity is there. This is again another post-tricuspid, that PDA which we have already seen. And see, this is an infant with a large PDA. This could easily go for a large VSD also. So there are limitations to chest X-rays in deciding between the post-tricuspid shunts, right? Except the aorta. So I have given you a chart. But this is possibly useful. The starred ones are more important. For example, apex, RV apex for a ASD, whereas LV for ductus, LV or RV for a VSD, depending on pulmonary hypertension. Right atrial enlargement mainly for a ASD, left atrium for PDA and VSD. Pulmonary venous hypertension, very important. Aorta, I think they usually ask you this question. That is, aorta is least prominent in ASD, most prominent in PDA, and normal in ventricular septal defect. So you should remember that these are all soft findings. And as I told you, it is sometimes very difficult to distinguish between. Only thing is, if you have a high volume pulse and cardiomegaly, LA enlargement, you think most likely it is going to be a patent ductus arteriosus. Nikhil, how much time do we have?
Yes.
I have no problem, but you. Now it is 11:15.
Yes, sir. More half an hour we can continue, sir.
Okay, 30 minutes we can continue. Okay.
Yes, sir.
Yes. Okay. So you tell me when 20 minutes are up. You keep a time. Now it is 11:15, right?
Yes.
So whether to accelerate or not, we will see. Okay.
Yes, sir. Yes, sir.
Yeah. This is a older boy with symptomatic, and he is having dyspnea on exertion, functional class 1. And his saturation was tantalizingly 94-95. Nikhil can answer. After that, we will go to another person.
Yes, sir. Sir, saturation, you are saying something, sir?
94-95. 94. Very tight saturation.
Yes, sir. Yes, sir. One second. Sir, this is a chest X-ray, sir. Looks like a AP view. Then coming to
this looks more like a PA view, but anyway, doesn't. When in doubt, you say frontal view.
Yes, sir. Yes, sir. Coming to situs, I can't see, sir, gastric shadow, but looks like a situs solitus only. Then cardiomegaly, sir, looks like a 0.5 ratio, 0.5 or less than 0.5. So there is
less
no.
Than 0.5. Okay. Go ahead. Anyway, there is not much of cardiomegaly, correct?
Not much of cardiomegaly. Coming to borders, it looks like a RV type of apex, sir.
Okay.
RV or maybe I can't appreciate, sir. That also I can be frank.
Okay.
Then chamber RA looks like mildly enlarged, sir. It doesn't look.
RA is enlarged or not? Enlarged.
RA is enlarged, sir.
Enlarged.
Yes, sir. Yes, sir. Then arteries, great arteries, PA is dilated, sir.
What PA? MPA. Yeah, you don't say MPA now. You're a subspecialty student. You should say MPA or LPA or whatever. MP is dilated. LP is dilated. And RDPA, that is right descending pulmonary arteries also.
Pulmonary arteries also dilated. Yes, sir. Yes, sir. Pulmonary vascularity is, sir, it is not decreased. It looks like normal, sir. Pulmonary vascularity. If you see the right side of the pulmonary vascularity.
Yeah, you can go up to the lateral, but on the left it is not very clear.
Yes,
but so.
Yes. So diagnosis. Is it isolated PS, sir? I can based on the clinical.
PS, isolated valvular PS.
Yes, sir.
Isolated valvular PS because you are saying and you think it is a poststenotic dilatation, RV apex, and a right atrial enlargement. But then, if you look at you tell me about the RDPA. You describe the RDPA. It's a white thing at the hilum. Then, as it comes along, what is happening?
Sir, as it.
It is becoming smaller and smaller. No, there is some sort of a little bit. Anyway, but you should know. Okay, you are talking about a PS situation, but vascularity, we are saying it is normal, which can occur in valvular PS. Okay, now I will show you another X-ray. Another X-ray.
Okay.
Here is another patient, similar presentation. So, what is the difference?
Yes, sir. Here we can clearly see there is a decreased pulmonary vascularity, sir.
Yes.
There is a peripheral pruning also.
Yes, also.
So this is MP. Yes, yes.
MPA dilatation, right?
Yes.
Must be.
So this must be PDA with. I mean, Eisenmenger physiology. We can have one of the.
Never say PDA and all. Never ever say. You say most likely Eisenmenger. I will come to that later, but basically you are thinking of a severe pulmonary hypertension. It can actually be even what you call as an idiopathic pulmonary hypertension, maybe. But Eisenmenger is probably more common in pediatric practice or adolescent practice than this thing.
Yes.
Next person, another person, Nikhil.
Dr. Rufus, you are there? Rufus.
I am there.
Yeah, Rufus, good morning, good afternoon, good morning. This is an 18-year-old person who is symptomatic, functional class 2, saturation 90%. 90% means on air means this particular person has definitely a congenital cyanotic heart disease. She is Padmini, lady. Unfortunate to have such a situation. So, what can you describe this?
This is a chest X-ray AP view, sir.
Yeah.
Levocardia, situs solitus.
Mm-hmm.
And the CT ratio looks around 0.6.
Correct.
And there is a dilated pulmonary main pulmonary artery segment.
What about LPA and RDPA?
The LPA also looks dilated, sir.
Looks dilated or dilated?
It's dilated, sir.
It is striking, no? Okay, then
Yes,
what about RDPA? RDPA is also very huge. It's a huge RPA, no? RDPA is very huge. So you have a modest cardiomegaly with a hugely dilated MPA, LPA, and RDPS. Vascularity of the lung appears to be?
It's mainly oligemic.
It's difficult, maybe oligemic or normal or whatever. So this actually is an X-ray of an Eisenmenger. Which one? ASD, VSD, PDA? Choose.
ASD, sir.
Correct. Why? 2 points.
Cardiomegaly, sir.
Yes, very good. And a hugely dilated pulmonary. So you must remember very honestly, sometimes it is very difficult to distinguish between what kind of Eisenmenger is there. But one practical point which we know is that cardiomegaly is slightly more in favor of a atrial septal defect, and very much dilated pulmonary arteries are also slightly in favor of ASD. Otherwise, sometimes it is very difficult to distinguish this Eisenmenger business. I will Nikhil, please remind me to tell you about one point about Eisenmenger at the end of the discussion, right? Just remind me.
Yes.
Another X-ray with a mild cardiomegaly, hugely dilated, which our Nikhil had already seen. This was actually a large VSD with Eisenmenger. This was a ASD Eisenmenger, and this was a VSD Eisenmenger. And Rufus, so you can see that. And now on your right hand side, I have shown you very clearly hugely dilated RDPA going down, becoming narrower and narrower and narrower and narrower. What is this called in fancy terms? Some animal, small animal.
Elephant trunk, sir.
Elephant trunk. Elephant is the largest land animal thing. The only animal which crosses this is a blue whale. I am saying small animal. Rat tail appearance. This is called the rat tail appearance, or a prune tree appearance, or what you call as a peripheral pruning. So this right sided X-ray was also a near Eisenmenger. It was actually a near Eisenmenger. Actually, we could manage to operate on this patient because the saturation was normal and shunt. I mean, all those things were reasonably okay, but difficult, high risk surgery for a large VS. So you have seen ASD Eisenmenger, VSD Eisenmenger, and this is the third Eisenmenger. This is the which Eisenmenger? PDA Eisenmenger. Rufus, tell me 2 reasons why this is likely to be a PDA Eisenmenger.
Because we are seeing the ductal calcification.
Absolutely, very good.
And aorta is also dilated.
Aorta is definitely very super. I think that is the point. These are only 2 points which tells you that these are all X-rays very important for you in the examination. But very sad for those people who have this problem. You know, you haven't. What is the What is the 10-year survival of an Eisenmenger, Rufus?
If it is idiopathic, then they have
no. Eisenmenger VSD or a PD. 10 years or 80%. Right. If it is an IPH, it is only 30%. Okay. So ductal calcification not only can occur in a Eisenmenger, also in ductal aneurysm in an adult also you can get a ductal aneurysm with the calcification. And there I think if it's a correctable surgery, you should do a device closure rather than a surgical closure of the PD. Anyway, So these are some points to theory. You can write all those things, but the final points are only three: presence of cardiomegaly in ASD. Proximal PAs are very huge in ASD. Aorta is small in ASD, normal in VSD, and enlarged in this thing. And ductal calcium, which tells you that this is very, very important point, very, very practical point. You should, this is a very important because very likely that one of you will get, many of you will get an Eisenmenger situation. They are unfortunate people who are regularly are present in during the exam season. And this is actually another one, which is a idiopathic, unfortunate boy with idiopathic pulmonary hypertension. But suppose this was an Eisenmenger, which Eisenmenger is likely this one, if it is an Eisenmenger. Anybody?
PSD.
PSD, exactly, precisely. Now another person, post Rufus. Rufio was a great military man who was a right-hand man to Julius Caesar. So you have so you should become a very good cardiologist. Who's the next person? Okay. Anybody? 7-year-old boy, asymptomatic basal murmur. So
yeah, Deepthi, you can take it.
Yes, definitely.
Deepthi?
Yes, sir. Yes, sir.
Yes. Okay. So you have a basal murmur asymptomatic, two possibilities. You are dealing with a pulmonary stenosis or you are dealing with an aortic stenosis. That's all primarily. And this is an X-ray. Can you read this X-ray?
Yes, sir. Chest X-ray. PA view. Levocardia, situs solitis. There is no cardiomegaly, sir.
Okay.
Looks like LV apex, most probably LV apex. Right atrium is normal.
Right atrium, you see the right atrium, it occupies 1, 2, and 3 spaces vertically. So there is a right atrial enlargement. Okay. Then
Aortic knuckle is prominent. Pulmonary artery is also prominent.
Okay. So pulmonary artery is dilated. Pulmonary artery is dilated. So see what is happening is that this is the main pulmonary artery which continues as the LPA, and this is the right descending pulmonary artery. So MPA is dilated, LPA is dilated. This is also dilated, but this is more dilated. Like in animal farm, some animals are equal. All animals are equal, but some are more equal, something like that. So this actually, and the vascularity I want to know, is it normal or reduced or increased?
Vascularity is normal, sir.
Exactly, very good. See, this child actually had a moderate valvular pulmonary stenosis, right? So even in moderate valvular pulmonary stenosis, vascularity is normal. This is a standard question asked in the examination. What is the vascularity of a moderate to severe valvular PS? The answer is vascularity is usually normal because there is no exit, any other exit for the blood to flow. So the entire blood RV receives has to go to the pulmonary artery. So vascularity in an X-ray will be normal. Only when they go for a right heart failure and the right left shunt across the PFO, you will have a reduced pulmonary vascularity. As you see here, this actually I had shown you to show you the right atrium, but this actually was a neglected valvular PS which became like this with mild desaturation, and there was a surgical valvotomy was done for in Chitra. So only situation where vascularity is reduced in pulmonary stenosis is when they go in for a right heart failure with a right to left shunt, in the end stage of a valvular pulmonary stenosis. And your name is what? Your name? Deepthi. This is another boy with a basal murmur. So you have already covered which one? PS. So this must be Yes, aortic stenosis. This is a very classical X-ray of aortic stenosis. You see the left ventricle. So here you can be 100% sure when you say this is an LV apex, elongated heart going down, right? Laterally, everything is fine. And you have this X-ray. And this is another X-ray. Here, what is more striking, Radha?
Right aorta.
Sorry, right aorta. See, there is a ascending aorta is very much dilated, right? Vascularity appears to be normal. This is AS will be kept. See, the point is, these are all older children, and this is an adult, this is a child. But you see, if you have a severe AS in a newborn, it will simply look like a large heart, nothing else. There will be no other clue to make a diagnosis. Only when the child becomes older, their X-ray findings will help you to reach a possible diagnosis. That is the lesson to be learned. So this could be an X-ray of an Epstein, this could be an X-ray of a critical coarctation, anything is possible, or a dilated cardiomyopathy. Not 3 days non-dilated cardiomyopathy, but could be critical coarctation also, very important. And this was an 8-year-old boy who was asymptomatic. This X-ray is one of my very favorite X-rays. I'll tell you why. 8-year-old boy, asymptomatic, BP 150/76. That is high blood pressure, no? So if you have a high blood pressure in the upper limb, you should think of in a boy? Coarctation of aorta. And this is an X-ray. Can you read this X-ray?
Chest X-ray, PAU, levocardia with situs solitus.
Correct.
Right atrial enlargement is there.
No, what about the RV-LV contour?
It's an RV contour, upturned apex.
Okay.
And three sign is there, reverse 3 sign, prominent aortic knuckle.
Precise.
And a segment, and again a prominent segment is there, which is like reverse 3 sign, and there is rib notching, inferior rib notching from third rib, third, fourth.
Correctly. So naturally it has to be coarctation. See, the most interesting thing is an older child, and we thought it is basically an RV contour because of a upturned apex, right? But actually it cannot be, it has to be only LV. So sometimes this happens. Severe concentric LVH in an X-ray sometimes will look like this. This is basically because of a concentric LVH, which has been reported in literature. And what is most important is the 3 sign you mentioned. You have a 3 sign, that is the proximal is basically a dilated aorta or a dilated subclavian artery, and the distal one is a dilated post-stenotic dilatation. And if you put a barium, you will find a E sign. And as she has mentioned, very classical rib notching here and here. So this X-ray is very important. I mean, this kind of X-ray is very important to me because when I went for a test for entrance examinations in Sri Chitra, my senior colleague who was exam going student told me, Zulfi, when they give you, suppose they give you an X-ray which looks almost normal, more or less normal, don't look at the heart, look at the ribs, there will be a rib notching. So this is a typical rib notching in a coarctation of aorta. Now this will serve as a homework for you. You should go back and read about collateral circulation in aorta, both anteriorly and post. There are 4 types of collaterals happening in aorta. Coarctation, which you should thoroughly learn very well, and they can ask you that question. Second is why only from third onwards you have the rib notching, and what are the other causes of rib notching, like SVC obstruction or a neurofibroma or a schwannoma, because they also run in the inferior margin of the ribs. Then they will ask you about a unilateral rib notching. So that is also important. For example, if you have a coarctation with some obstruction of the left subclavian artery, only one side, right side, will have the rib notching, something like that. So I think that area is very, very important because we have less time Otherwise, maybe Nikhil and I will devise some way. If we have a web and all, we will devise some way by which this kind of tricky questions can be answered in some way. We will see that later, but time is slowly running out. This is a 4-month-old baby. 4-month-old. Yeah, 10 minutes more now.
Yes, sir. One last, sir, few last X-rays we will have, sir. We'll have last volunteer, sir.
Okay, one more volunteer.
Yes, sir. I've not taken anyone from Bombay. Sir, anyone? Saurabh Daria, you are there? Saurabh?
I'm there.
Yeah.
Saurabh is there.
Okay.
Saurabh is there. Okay. I know one Saurabh who is an assistant professor in All India Institute. Very great. He has written a very huge review article on malpositions from Chitra. I mean, from a lot of information. Anyway, so he was a student of Sri Chitra, and one of his best paper on full review article on cardiac malposition, which you should read. Anyway, this is a 4-month-old baby symptomatic with cardiac failure, and this is a huge heart and recent onset heart failure, and we basically echo showed LV function is very poor, and we are tempted to diagnose what's a dilated cardiomyopathy. But in this particular patient, I want to know from Saurabh, can an ECG help in making any helpful diagnosis that is helpful towards the child?
So ECG will definitely help us in giving information for enlargement of heart chamber like RV or LV or pressure or volume overload, sir.
Okay, what else?
Then we can get even atrial enlargement like right or left atrial.
Will it, because when we commit that this is DCM, we are committing him to a lifelong medical management till life lasts.
Yes.
So will ECG make a difference to his life? Somebody said Al-Kappa, right? So that is very important. Whenever you have a baby below or near with DCM, always look for a correctable condition like an Al-Kappa, a tachycardia induced cardiomyopathy. Nowadays very costly, but Pompe also can be treated with the enzyme replacement. Now I will quickly go through this. It's a 5-year-old girl, acutely symptomatic, fever with heart failure, with a chest X-ray like this. You must be very familiar with these X-rays. We are very unfamiliar. We have very few cases of this. What is this? What is the diagnosis?
Sir, straightening of the left heart border, sir.
No. What is the probable diagnosis? Acutely severe pulmonary edema. No, it's a 5-year-old girl. Very young, too young to have mitral stenosis.
Acute MR, sir.
Exactly. It was an acute MR. You should know acute MR can present. This was an acute MR, and we were in a dilemma whether it was a infective endocarditis or rheumatic fever, but turned out to be rheumatic carditis and acute MR. You should know the causes. This is another acute MR. Again, this is a recent myocarditis which we had in our hospital with pulmonary edema. This is a chronically ill symptomatic child who had a big heart. See, this of course was a dilated cardiac. You see the apex here. Here also the apex is what? Upturned apex, no? So we will be tempted to say what RV apex, but this is actually LVH. So everything is possible. You can have a LVH producing a upturned apex, like in the coarctation of aorta sometimes. And this, of course, is different. What is this likely to be?
The pericardial effusion, sir.
Most likely, global pericardial. Cardiophrenic angles are obliterated. So whereas this is not obliterated. Very important to know the cardiophrenic angles are not obliterated, and you have a very big heart. That's the difference between pericardial effusion and dilated cardiomyopathy. And this is, I must skip. This will be kept in the examination.
This is pericardial calcification, severe pericardial calcification.
Yeah, so most likely cause in our country.
Tubercular pericarditis.
What is that? Physiologically, what is the condition? Most likely.
Constrictive pericarditis.
Yes, it is most likely going to be a a constrictive pericarditis, because one of my teachers used to say that if a candidate, a DM candidate or a DNB cardiology candidate can knows thoroughly the physiology of a constrictive pericardial or a pericardial disease, he's fit to pass. So you must go back and read very thoroughly again and again the hemodynamics of a constrictive pericarditis, comparison with a restrictive cardiomyopathy, etc. very thoroughly from Braunwald. This is a symptomatic child. Wow, yeah, that is the one which almost close. This is a child who was symptomatic, was cyanotic, no murmur. It's a spot. Anybody else?
Pulmonary AV fistula.
Yes, most likely a localized pulmonary AV fistula, which will be kept in the examination. So only a contrast echo can know that echo will be considered as normal, and only contrast echo will tell you this is thing. Fortunately, this was a relatively localized one which was plugged and all. But sometimes what can happen is it will be diffused bilaterally, nothing can happen. Right? And this is a severe pulmonary hypertension. I told you, I think I showed you all this. Then simple spotters, only 5 minutes now. Some foreign structure is there. What is that? Anybody can answer. Louder.
PDA device.
Yeah, it's a device closure for PDA. And this again a device. ASD device in a patient. And you have a device in somewhere else. It's a
VSD.
Which VSD is likely? Muscular VSD. But you must remember that Fortis is in Bangalore, and Dr. Vijayalakshmi Madam is very good in closing perimembranous VSD also. But generally, people play it safe by doing only a muscular, apical muscular or a mid-muscular VSD. And thank you very much. This painting, actually, this was an attempt on painting by my grandson, who is my apple of my eye. That is why I showed you this picture. And thank you. I think we have shot by 10 minutes, 12 minutes we have crossed anyway.
Thank you, sir.
No problem.
So, no, okay. So,
sir, I think you have covered all the X-rays, sir.
Yeah, I think so. Hopefully,
very nice collections.
Okay. But I am very glad, Nikhil, that I put Hari into you. I think it is he is very good. I am very proud to say that he was my old student, and also he has excelled. And he has written a book, monograph on balloon mitral valvotomy. He is an Indian authority on pulmonary hypertension. He had some international studies. Very, very, very talented person. So you met him also through. So
yes, sir. Yes, sir. People really liked us.
Yeah, both. And one more class is there for hardware, no? Hardware is for you.
Yes, sir. Yes, sir. Yes, sir. On Saturday we have kept, sir. And sir, yes, sir. Yeah. Sir, about your topic, sir, we will come to you, sir. Which topic to take next? I will discuss with my colleagues, sir.
Yeah, you discuss with my colleague, and after that we can see. And another thing is, I will send you with this PowerPoint. I will send you a small article of mine telling about how to read a pediatric cardiology X-ray, which also can be in Word, which will be
sent to
you. And then after that, there are some exam type questions. Some of the questions which we will find out a platform by which, for example, like the cooptation Y third and that kind of Y's and all are there. For example, that we will have a platform, not a class but a platform. Okay.
Yes, sir.
So,
yes, sir. Definitely.
You can call me maybe tomorrow or so. We'll see.
Yes, sir. Yes, sir. Definitely. Sir.
Okay. So thank you. The point is, when you grow older, you become fond of younger people. Like my grandson and you people, you are my students all of you must be younger than my sons. So you must be all in the late 20s and early 30s. So they're all younger to my son. So it's like It's like a parent-child relationship. Thank you very much. We'll meet again.
Thank you, sir. Yes, sir.
Sir, you told some points
sir.
about
Very
Eisenmenger.
Hello?
Sir?
Tell me. Yeah.
Sir, you told to remind about Eisenmenger syndrome, sir.
Yeah. There is one Eisenmenger syndrome. Actually, there is a journal in Kerala Journal of Cardiology, done basically by younger cardiologists. So I have there was one issue on PAH. So I have contributed an article how to differentiate between ASD, VSD, PDA, Eisenmenger in the exam setting. That also I will send to you. Very good. That is very good because that will be very useful to you in the examination. But you should know the limitation of clinical differentiation. Ultimately, you need a contrast echo or a catheterization. But you are likely to get this Eisenmenger syndrome very often in the examination, and these questions are usually asked. So these two things, that is how to differentiate these things, plus ECG X-ray reading, I will send along with the PowerPoint to Nikhil, so you can share that. Okay, so good that reminded. Okay, have a nice day. Thank you.
Yes, sir. Thank you, sir.
Thank you, sir.
Thank you, sir.
Okay.
Thank you, sir.